Is a traumatic disruption of the thoracic aortic wall after blunt deceleration. It's most often at the isthmus distal to the left subclavian. So usually these patients are in a high-speed MVC or falls, and this is the leading cause of death after head injury and trauma. What happens? This is a shearing or traction injury at fixed points of the aorta during rapid deceleration, and there are really 3 points where the aorta is anchored and can shear. This is the aortic root, the ligamentum arteriosum, and the diaphragm. And usually patients who shear at the aortic root and the diaphragm die in the field. So again, it's an intimal tear leading to an intramural hematoma, a pseudoaneurysm, and then a rupture. These patients often present asymptomatic, but they may have chest or back pain or obvious trauma to that area. They may have hoarseness. They may have upper versus lower extremity blood pressure discrepancies or present in shock. But if these patients are in shock from an aortic injury, they most likely aren't going to survive for very long. How do we diagnose this? So a CT angio of the chest is gold standard. You might see a widened mediastinum on chest x-ray or an apical pleural cap. And grade 1 is an intimal tear. This is a tiny flap less than 1 centimeters and no external contour abnormality. Grade 2 is an intramural hematoma or a larger intramural flap. Grade 3 is a pseudoaneurysm, and then grade 4 is a rupture. Start with an esmolol IV infusion. This is a beta blockade, and you'll titrate this to a heart rate less than 80 beats per minute. Once the heart rate's controlled, you'll want to lower the blood pressure with nicardipine or nitroprusside or nitroglycerin to target to a systolic blood pressure between 100 and 120. Step 3 here will be pain control to minimize agitation. Definitive therapy is different based on the grade. Grade 1 is often non-operative, and this is just surveillance of these patients. Grade 2 through 4 is often a TVAR if anatomy allows, and an open repair if not.